Thank you so much again for the invitation. Thank you for the panel members and the scientific committee. These are my disclosures. So Dr. Ayman Hassan, I think he gave a great presentation actually on the DEB-TACE, which is what we're gonna talk about here also. Great presentation, so congratulations. What I'm gonna do is I'm gonna just give a little bit of more touches on how to optimize the technique in order to obtain better results. To optimize the TACE technique, there's two main things that you have to do. Number one, patient selection. Without good patient selection, your outcomes are never gonna be good. So you cannot just do TACE for everyone. And there's also technical pearls for those who work in interventional that's hopefully will be very helpful for them. So when I did a Google search on, TACE, this is what came up. The first TACE publication was in a French journal in 1973. And they were debating at that time whether TACE is equivalent to what they used to do at that time is like surgical ligation of the hepatic artery as a modality of treatment, is like doing TACE at that time. And since then, of course, there has been a lot of modification and advancements in the technique and in the treatment itself that evolved over years. So in terms of patient selection, which is, of course, very, very important, you cannot just do TACE for everyone. So TACE is mainly done for BCLC-B. And that's, again, a little bit of an addition to Dr. Ayman Hassan's presentation, is that there's a new BCLC algorithm, which is what you see over here, that was published in 2022. And we all know that the BCLC-B patients, which is the intermediate stage, is a very heterogeneous group of patients. And it includes lots of patients with different liver functions, whether it's diffuse versus infiltrative versus well-defined masses. So TACE is indicated for well-defined nodules or masses or HCC with preserved liver function, and it's better to do it selectively, again, on a segmental basis. This is when you do TACE. Otherwise, the other patients in that same BCLC-B group will either go to transplant or to systemic therapy. So again, because of the heterogeneity of this group, which was described first by Bolondi in 2012, I think, which was described in 2012 by Bolondi. Again, they had to reformat this into selective patients who go to TACE. TACE is also, I don't think it's working. Oh, okay. This is also can be used for stages 0 and A, like early stages, basically. And this is the patients who are eligible for the curative treatments, basically ablation, resection, and transplant. If these modalities are not eligible, the patient is not eligible for these modalities, basically not feasible or failed, then you can do TACE as well. So these are the indications, or it's very, very important to know that these indications for good patient selection. Now, part of the BCLC, as you can see here, is preserved liver function. So how would you assess the preservation of that liver function? Of course, we know that there is Child-Pugh, which is mostly described in most of the studies. They do TACE for those patients who are Child-Pugh A. Now, there's a better risk assessment module, which is the ALBI score, which is basically relies on albumin and bilirubin. That's what it's called, ALBI. And you put these values in this sophisticated equation. There are scores actually now, like websites that calculate that automatically for you. And you put it in that equation, and the results is always in the negative. And the more negative it is, that means the patient actually has a better preserved liver function. So there is ALBI1, 2, and 3. And as you can see, ALBI1, which has better outcomes, is more negative than ALBI3. This is the study that was done in Germany, trying to see how ALBI score compares to Child-Pugh, and you can see the separation of the curves when you compare ALBI1 to ALBI2 versus when you compare Child-Pugh A versus B. The separation of the curves here is more, which shows you that ALBI1 actually survived better than ALBI2. So it has a better risk assessment for these patients. If they are ALBI1, of course, do it. If it's ALBI2, you can think about it. If it's ALBI3, it's better not to do it. Technical considerations, there's 5 technical PAARS I'm going to talk about today. Of course, there's more, but these are the main ones. First of all is to use segmental or subsegmental approach, to use small and shaped microcatheters, to use cone beam CT, and to address extrahepatic supply to the tumor, and to use small drug eluting bead size. In terms of using segmental and subsegmental, again, the more you advance your microcatheter in the liver towards the tumor, the more your results will be much better. This is an example of a lesion in segment 8 at the dome of the liver. As you can see it here, it enhances on arterial phase, washes out on portovenous phase. Here's our angiogram, and the lesion is right here. We kept going with our microcatheter very selectively into these arteries with a very, very small microcatheter. We use up to like 1.7 French sometimes to achieve this location. And then at that point, we injected the DEB, or we did the DEB-TACE. And this is how you can see there is complete filling of the tumor as well as the liver around it. Here's how it looks. This is cone beam CT, again, showing complete filling of the tumor as well as a margin around it, which is necessary, of course, for micro cells. And this is the follow-up after 1 month. You can see there is complete response of that lesion. Second one is to use small and micro and shaped microcatheters. Sometimes you cannot get easily into these very small vessels to get very close to the tumor. An example of this is this catheter here, which is 1 French microcatheter that we have driven all the way into this big tumor here. And you see this tortuosity here. It's actually a 2-plane or a 2D image, but if you really do the lateral of this, there's also tortuosity on the lateral side as well. So it's really sometimes difficult, requires very flexible microcatheter, very small microcatheter. This is the follow-up after 1 month, showing complete response of that lesion by ESRNM. Now, this is also an example of another tumor that was in the left hepatic lobe in segment 4A, and this patient has abnormal or variant anatomy in which the left hepatic artery is arising from the left gastric, and there is this artery that goes off from here, basically, which is this one, that feeds the tumor. You have to, again, catheterize and go very far into that artery in order to do TACE, and that usually produces the best outcomes. Use of cone beam CT. When we started having cone beam CT like 10 years ago, we really didn't know what to do with it. It's just like this baby, what do I do with my hands here? So, but then we realized that it's very, very helpful. Cone beam CT is now just a standard part of any TACE or Y90 procedure, or even, sometimes we do even ablation on the angio machine using cone beam CT. So it's very useful in visualizing the arteries that feed the tumor. It's also very important to assess complete therapy to make sure that you have covered the whole tumor and there is no other arteries that are supplying the tumor that you have missed. It also affects the technique in 25% of the patients. So let's talk about the first one, which is how do you see the feeding arteries? There is something called IMBO guide in which you do cone beam CT and you see the tumor. As you can see here, you draw a region of interest around the tumor, and then you put a pointer on the tip of the catheter right here, and then it will tell you all the arteries that feed this tumor. So you can go into each of these arteries if they are big enough, or you can basically plan to put your catheter proximal to these arteries so you do not miss any of them. So when you inject your beads, it goes into all these arteries and you get complete coverage of that tumor, like what happened in that particular patient here. You can see there's complete coverage of that tumor. Second one is to assure complete therapy. This is an example of an HCC that is sagging from segment 3 at the bottom of the liver right here. And again, we did the same thing. We went with a microcatheter, very distal, as you can see here, very close to the tumor. Here's a tumor right here. And then we injected the chemoembolization material. And you can see when you do the cone beam CT, you can see that there's complete coverage of that tumor. It's complete, the chemoembolization penetrated well into that tumor. Here's the follow-up after 1 month, complete response and complete necrosis by ESRNM. Next is addressing extrahepatic supply. So if you do TACE and then on the follow-up after 1 month, you see that there is basically some residual tumor. It's actually not recurrent. Don't say this is recurrent. This is a residual tumor. There's no time for it to recur again. This is what you left behind after doing the TACE. So, or the better than this is to do cone beam CT at that time, and to see part of the tumor only is filled with the chemoembolization material and the other part is not. So either way, there is part of the tumor that is actually being fed by a different artery than the one that you treated. In these cases, you have to look for other arteries that can supply that tumor. This is the list of arteries that can actually supply an HCC, amazingly, almost everything. And I will show you some examples of this. This is the inferior phrenic artery. Here's a large HCC, and you can see even on the CT, there is hypertrophy of that artery here compared to the other side. So the right inferior phrenic artery is hypertrophy compared to the other side. So we expect that probably this is going to is feeding that large tumor. And indeed, when you do the angiogram, you see that this artery, again, larger than the other counterpart, is really large and it's feeding a huge part of the tumor. So you gotta have to embolize this one. Again, when you do that, you have to go distal to this artery, which is the adrenal artery. You don't want to embolize the adrenal gland. So you have to really move your catheter superior to this in order to embolize that area that is fed by the inferior phrenic. This is another example. I'm not going to spend much, but it is from the left inferior phrenic. You can see there's a tumor here that is fed by the inferior phrenic. You can see this is part of the tumor. Again, do the same thing. Here's an example of a cystic artery, the artery that goes to the gallbladder. Here's a large tumor in segment 6. Here's the gallbladder. When we did the angiogram, part of it was supplied by the hepatic artery, which we embolized easily, but then part of it was actually supplied by this artery, which is the cystic artery. So we catheterized the cystic artery, as you can see here, and indeed it is supplying this part of the tumor. So we went even further with a 1.7 French microcatheter in order to avoid any, or injecting chemoembolization material into the cystic artery itself and damaging the wall of the gallbladder, which is likely to happen as a complication of this. But we went far distal and we did chemoembolization from that location. Here is before and here is after. Almost complete response. Gallbladder is still intact. Again, you have to be careful when you do this, of course. This is an example of another case that when the patient did the follow-up, there was actually a residual tumor. Again, it's not recurrent, it's residual because it's only after 1 month of follow-up. So we went back, and when we did the angiogram from the hepatic arteries, there was nothing really feeding the tumor. But then we noticed that there is this tiny little artery, which is an omental artery, that is moving here and then feeding that part of the tumor, which was in that area. You can see that there is areas of void of any vessels, which was the result of doing the chemoembolization from the hepatic artery. But there was also this omental artery that was actually feeding it. So again, we went with, you can see all these loops with the microcatheter until the tip is right here, and then we did chemoembolization at that location. It could be also from the internal mammary. Imagine that comes from the subclavian. It can go down and feed dome tumors like, I don't know where here it is. So this is the lesion at the dome of the liver, again supplied by this artery, which is the internal mammary artery. I got this case from one of my friends in Mallinckrodt at that time. So right renal artery, again, right renal artery can give HCC. Here's an example. Here's the right renal artery. Here's the kidney. And there's this artery that goes up to supply that lesion in the liver. You have to catheterize that artery. Here's the tip of the microcatheter. Here's the lesion. And then you embolize that. It could be even from the suprarenal when the lesion is very close in segment 6 or 5. In segment 6 in specific, when it's very close to the adrenal gland, the suprarenal artery can supply that. Here's a suprarenal artery, and it's feeding this, which is the tumor, and then you have to embolize it. Here is an example of an intercostal or lumbar artery. This is an intercostal artery. Again, tumor that had residual disease on follow-up. Here is the intercostal artery. It goes up, down, and then up here to feed the tumor. And in these cases, you have to really place your microcatheter here. You have to avoid embolizing all these tiny little branches because it causes a lot of pain. These are the intercostal. So you're going to create intercostal muscle ischemia, which is very, very painful for these patients. So you really have to be, again, close to the tumor in the vertical part of the artery. It could be also from the colic even. Colic artery can feed that, which feeds the colon, especially the right colon. That can feed an HCC that is sagging like this one from segment 6 or segment 5. And you can see here, this is the microcatheter inside the superior mesenteric artery, and then here is the right colic. And you can see the tumor is here, so we try to drive our microcatheter as further up as possible, inject it, and you can see here, this is the chemoembolization material inside that tumor. Again, this is not without complications. These are the type of complications that you can get if you try to embolize these extrahepatic arteries. Again, this was published from our institution. So again, you have to really have excellent microcatheter skills in order to be able to get into these extrahepatic collaterals. Everybody can go through the hepatic arteries, but it's sometimes difficult to get into phrenic, into omental arteries, into this, into that. So you have to really have good skills in order to be able to navigate between these arteries. Otherwise, you get very frustrated, like this, soccer player Mo Salah. The last one is the use of small drug-eluting bead size. Again, I think, Ayman touched on this, but I'm going to touch on it in a slightly different way. These are the beads that are available in the world. Live pearls, DC or LC beads, hepasphere or quadrisphere, tandem or oncozine. In America, we try, for some reason, they try to name it differently, but these are the same products. We just call it oncozine. In Europe and the rest of the world, they call it tandem. Hepasphere, we call it quadrisphere. Anyways, you can see from this microscopic image the difference, the huge difference between all of them. We don't use this in America anymore because of the clumping that you see in this microscopic image. This is just an inferior product to all the others. Live pearl is not FDA approved, so we also don't use it. So the only two that are used are actually the LC beads and the oncozine or tandem. So this is again a very nice table that shows the differences between both of them. These are again the most commonly used ones, the LC beads and the oncozine. We always use smaller size than usual. They use the smallest size. And that's very, very important to understand. Nobody uses 100, 300 anymore, or even bigger than this. Everybody has to use smaller beads in order to provide good penetration into the tumor. If you use large beads, this is where your beads are gonna stop. If you use smaller beads, you're gonna penetrate inside the tumor, and then the release of your chemotherapy will be much better, which is a study that was done actually on guinea pigs, on a swine model, where they compared the small size particles with the large size particles, as you see here. They found that the small size particles penetrate distally into the arteries. They have more homogeneous spatial distribution, like they distribute nicely compared to the bigger ones. And they also have a higher concentration of the doxorubicin, which is or adriamycin. It's called adriamycin here. Again, we try to call it something different in the US for no reason. The small beads, as you can see, here is the micro CT that was done for these swine models. You can see there is more penetration distally compared to here. There is more homogeneous distribution compared to like this area here did not really get, good beads, okay? And not just this, but there's also increase in the number of beads, which results in more, the red halo here represents the doxorubicin under fluorescence, and this also curve shows the distribution. You get more concentration, of the doxorubicin when you use the small particles compared to the large ones. So is the small particles associated with more side effects and toxicity? Here's the study that was done in Mass General in 2015, comparing again small and large beads. You can see that there were more hepatobiliary adverse events with the small beads compared to the large beads. This was gastrointestinal hemorrhage, biliary dilatation, ascites, and cholecystitis. However, they didn't really find out what's the reason they had more complications with the small beads compared to the large ones. But just to let you know that this study was not perfect, because 80% of these patients were treated at the lobar fashion, which we don't do anymore. We always try to go very selective. We don't just go into the right hepatic artery and spray the beads everywhere. We usually go selective into the artery that is supplying the tumor. So to back up this, another study was done, which is a retrospective study done in, I think in Italy, comparing, again, small size with large size. They looked at, overall survival as well as progression-free survival. There was, of course, better overall survival and progression-free survival results with the small beads compared to the large beads. In addition, when they looked at the radiologic response, it was significantly different in favor, again, of the small beads. So it improves your radiologic response, which later correlates with your progression-free survival and overall survival. And when they looked at the safety or the adverse events to compare it with what the study from Mass General showed, they actually didn't find any difference between the two groups. The 30-day mortality even was equivalent between the two groups. There was no more than grade 3 adverse events, which is what we actually care for. Grade 1 and 2 is usually treated by symptomatic treatment. Grade 3 is when you start seeing like really nasty complications from the treatment. So in conclusion, use segmental and subsegmental approach. Go as close as possible to the tumor as you can. Use cone beam CT to locate the feeding arteries so that you do not miss any of them. And also to ensure that you have completely covered that tumor when you inject the chemoembolization material. Search for extrahepatic supply if you have any residual tumor, whether on follow-up or during the cone beam CT that you do during the procedure. And of course, use very small size particles, the smallest that you can get. I'm not sure if it's available here in Egypt or not, but small size particles allow better penetration and better distribution and higher concentration of the doxorubicin or adriamycin. And with that, I'm going to end my talk, and thank you so much.